Good afternoon and welcome to the Providence Institute for Human Caring's Humanizing Healthcare Expert Series. Today we're going to talk about a unique telehealth project to support palliative care in critical access and rural hospitals in Eastern Washington and talk about how that model might be replicable or generalizable to other programs. Just a few housekeeping items. You will be muted if you have comments or questions. Please enter them into the chat box and we have moderators who will handle it from there. And if you have colleagues who are unable to attend today, they may be able to watch it later through the recording that will be made, and information on the recording will be provided. Well, it's my honor to co-present with my friend and colleague, Dr. Kevin Murphy, who's the Executive Director of the Institute for Human Caring's Palliative Practice Group and tele-palliative care. And also with palliative care nurse Amber Moody, who works at Mount Carmel Hospital in Colville, Washington, and St. Joseph Hospital in Chewelah, Washington. And I'll let Amber describe a little bit about the geography of Stevens County in just a little bit. So the Providence Institute for Human Caring is an organization that is focused on improving the quality of health care for all. We look at how do we care for whole people, how do we make sure that health systems are designed in ways that recognize the inherent dignity and integrity of every person they serve, and how can they improve the health of communities by doing so. And so now I'm going to ask Amber, our nurse in Stevens County, to talk a little bit about rural healthcare, living and working in a rural environment. And Amber, maybe you can start by telling the origin story of the title of this talk about dairy cow schedules. Amber?
Sure, Greg, I'd be happy to. I'm Amber, the rural part of our team. I work and live in Stevens County, Washington. The fun fact where our title comes from, that dairy cow schedules complicate things, is that we were scheduling a tele-palliative care consult for an intensive care unit patient. And as we were coordinating with their family, we get a text message minutes before we're supposed to start that they were still milking cows, and that dairy cow schedules complicate things. And so we learned that day, and we've encountered many similar scenarios as we've gone forward. So I'd like to review a few challenges that we have with rural healthcare. 15% of the US population live in rural areas. We often experience one or more of the following challenges: geographic isolation, lower socioeconomic status, older age, limited job opportunities, lower rates of insurance coverage. Less than 8% of total MDs or practitioners practice in rural areas. It's just hard to get doctors to our area. And limited access to specialty care that requires travel. In our instance in particular, we're about 70 miles away from a specialist. So where did we start? Well, a little background on Stevens County. We are actually a tri-county area: Stevens County, Ferry County, Poneray County. These three counties have a per square mile average of 17 persons, just to give you a little bit idea of how rural we are. Stevens County is the biggest county, and within that county are two critical access hospitals: St. Joseph Hospital in Chewelah, and Colville has Mount Carmel Hospital. We are located between the Canadian border, the Idaho state border, and the Columbia River, so the very northeast corner of Washington state. And a really unique part of our population is that 25% of our population in these counties are greater than 65 years of age. And that's projected to double in the next 10 years to over 50%. When you look at local or virtual, in 2008, Mount Carmel hired a standalone palliative care nurse, and all we had were local palliative care services. When you look at virtual, in 2021, we brought this tele-palliative program to our hospitals to then offer tele-palliative care. Our referrals are based on our hospital list. We are an inpatient program, so we have hospitalists out of Mount Carmel and also out of St. Joseph that refer patients to us for care. The RN triage part is me, and my team on the ground here. The chaplain and I are the boots on the ground part of the tele-palliative care. We meet the patients firsthand, meet their families, assess the needs, and then decide after meeting and what the needs of the patient are, whether we can handle it locally on site, or if we need the full interdisciplinary team or a tele-palliative consult that brings in all the other members. The social worker and RN dialogue happens daily. It's between the social worker on the tele-palliative team and the person here on the ground in the hospitals. It's a real-time review daily of what's happening, who's a new referral, and what do you guys need today. Our goal, along with great patient care, is to help reduce unnecessary transfers. We're about 70 miles from the closest large hospital, and these patients are often coming into the emergency room, and it may be the first healthcare they've received in 20 years. And so reducing transfers out of our county, out of their home environment is really important to them. The best medicine is local. These people are very community driven and they trust the people in their community. And by doing virtual visits, we are able to increase a family presence and involvement in the case of the patient. So how did we start? Well, we started back in 2008 with that sole RN and evolved in 2018 after 10 years to adding a chaplain. So we had an on-site palliative care nurse and an on-site palliative care chaplain. In 2020, our mission director of palliative care started work with the Washington Department of Health and its rural care initiatives, rural palliative care initiatives. That led to an asset and gap analysis being completed in March 2021. What we did was sit down and look at people in our community, businesses in our community, patients in our community, and try to figure out what the need was in Stevens County and the Tri-County area for palliative care. The barriers at that time were COVID and our location. We identified stakeholders by reaching out to community businesses, volunteer programs, and other healthcare facilities. When we reached out starting from basically the top of a list and working our way down through 22 different facilities. The facilities that were interested in helping us develop a palliative care program ranged from long-term assisted living, SNFs, EMS, the sheriff's office, volunteer fire departments, food coalition, rural resources, and mental health offices in our area. Once we knew they were engaged, we started having conversations with these 22 community stakeholders, trying to decide and determine what they wanted to see from a palliative care program. And a big part has been cultivating relationships here in the hospital between the hospitalist and the local team, between the local team and the tele team, and then in our community in general, where palliative care is a fairly new idea. We're able to really ask our community by being embedded in it and assess and deliver the type of care that the people in our community are wanting.
Compelling story for the needs that you identified there in Stevens County. And for those of you not familiar with geography in Washington, far northeast Washington, as Amber said, 70 miles north of Spokane. So that just begs the question, Gregg, how did this rural palliative care initiative that Amber mentioned and the palliative care team meet up with this local critical access hospital in Stevens County to form this initiative?
Well, Kevin, there were a number of factors that came together simultaneously, and I've always believed that serendipity is when preparation meets opportunity. And so the Rural Palliative Care Initiative had done a lot of the preparation. Amber mentioned the mission director, Kelly Corcoran in Stevens County, who was a very active part of the Rural Palliative Care Initiative out of the Washington Department of Health. I was also involved with that. Simultaneously, you and I had been spending the last few years working on, out of the palliative practice group, how do we set up tele-palliative care programs that can support our rural hospitals, including critical access hospitals. And so during the Rural Palliative Care Initiative, Kelly and I'm not sure which one of us first said, hey, maybe this palliative practice group tele-palliative care thing ought to consider Stevens County as a demonstration project site. And so then you and I began the process of working with the Stevens County team to bring that together. So these three different workflows, what Stevens County had been doing independently, the Washington Rural Palliative Care Initiative, and our palliative practice group tele-palliative care work all converged perfectly. And Kevin, you spent hundreds of hours over the last couple of years working on tele-palliative care development. I wonder if you would unpack for people a little bit, or what are the essential elements people need to think about if they're trying to develop any form of a rural tele-palliative care program?
Thanks, Greg. I think that I'm going to unpack that for just a second too, is that I hope that somebody does see this and say, wow, we can do that, or we need that, because one of the things that brought us to this point was, as you said, we had multiple conversations, and many of them were in between seeing patients or in between meetings and wondering how could we do this. And I know that when we first started talking about it, we really were focusing on just the rural areas of our small little microcosm in Southwest Washington. But as we started talking with system leaders, we realized that in Washington and many places across the country, in order to receive high quality, what is deemed best or top of licensed medical practice, you had to be in an urban setting at a university or at a tertiary medical center. In Washington, for example, you have to either be in a city or on the I-5 corridor. For those of you in California, I believe that it's called the 5. But we have a very large state that spans towards the coast or east over the Cascades. And those folks who choose to live in the mountains or are from the mountains or from the more rural regions deserve to have the best care possible. And so we started looking at how do we bridge that gap. And not many folks from rural areas want to just jump into the car and drive 3 hours to a hospital, but some of them can't. And some of them then end up being sent that's not really where they want to do. And so when we were talking about how do we bridge this gap, we knew that we as a health system, fairly large, 52 hospitals in 7 states, had a very robust palliative care program in many of our hospitals, but our smaller hospitals didn't. And how do you build a team in a hospital where the annual admissions in this one little hospital is less than the palliative care consults we have in this hospital over here? And so we started talking and really envisioned that our 13 critical access hospitals in Providence made a lot of sense. These folks deserve high quality palliative care. And so because of your work as the medical director for the Rural Health Initiative, and yeah, huge kudos call out to Kelly Corcoran, as you mentioned, but also Pat Justice with the Department of Health, just a phenomenal ally in designing and building and saying, we can do this, and putting all of the players in the same room to have that conversation. So I love this visual, the convergence and alignment of that destination pathway.
I might just take a moment, in addition to acknowledging Pat Justice and the Department of Health, acknowledging the work that Stratus Health out of Minnesota did to help with that project, and that's STRATIS if anybody's interested in looking into it. They've done some remarkable work on developing palliative care in rural settings. So as you're thinking about setting a tele-palliative care program up, Kevin, what are some of the essential steps like credentialing, privileging, whatever else you need to do, setting up a business contract, billing within your electronic record, all of those things?
All of those things and more. It was way more complicated than we thought. And I'll just be honest, and I'm going to probably defer the question a little bit because given the amount of time that we have scheduled for today, I think we would run over if I just got into part of that. But you're right. You have to be credentialed. Your physicians, your social workers have to be able to practice in the setting that you're setting up. Independent license, but also the contracting with the insurance and with the myriad of payers. Telehealth in some regions is historically allowed, in other regions not. With COVID, and this is really where we got kind of that final push, a lot of those restrictions on providing telehealth to rural communities were lessened. And so being able to launch this became kind of a no-brainer in that we had been talking about it, we had been planning it, we had been designing it, we knew that we could do it, And then COVID opened up a couple of doors for us, and we launched, as you know, early in 2021.
Yeah, I appreciate your calling out the public health emergency exemptions, because the model that we work right now, I wouldn't have been allowed to do previously, because I do most of my telehealth consults from home, and that would not have been considered an official originating site according to Medicare definitions. And so hopefully when the PHE exemptions are lifted, the public health emergency exemptions are lifted, those models will have gone there and allow different styles of practice.
Yeah, and only time will tell exactly what is allowed and what is continued. But a lot of the argument that we used to receive from many of the payers, Medicare, for example, there's no data that supports telehealth being a viable option. Well, we have a ton of data now from 2.5 years of a pandemic. So I think that we can probably argue against that.
So Kevin, I'd also be interested, we have this blended in-person and telehealth model that we use. What were some of the reasons that that model was what we landed on?
Well, this was all theoretical because the provision of tele-palliative care to a critical access hospital, we knew we wanted it to be as close to best known practices as possible. We have this interdisciplinary team designed and defined by brains much bigger than mine, and we've pretty much agreed with it from the outset. But we knew that we couldn't have a room full of people beaming into this hospital, and beaming in being the term that we use for the tele component of that. But when we looked at what it was that our most seriously ill patients needed and what they were missing in these rural settings, the rural hospitals exist. Case in point, these 2 critical access hospitals in Stevens County, they're fantastic locations, but they lack specialty services much of the time, and that's not unique. There's over 1,300 critical access hospitals in the country. There's 39 of them in Washington. So being identified as what's missing is kind of where we came up with this point. And, the best practices for palliative care, as you know, includes the provider, the social worker, the nurse, the chaplain. But we knew that all of our critical access hospitals had nurses bedside. And we knew that the spiritual care components in all of our hospitals, at least, was pretty robust. And so the part that we identified as being missing was the provider and the social worker, the psychosocial and the medical component of the specialty palliative care team. So we designed it that would be the part that we brought virtually to the team, and the bedside team would include both the attending physician, the bedside nurse, and any spiritual component that they had available there. But it's funny that you asked that, because we designed this in a lab for all intents and purposes, and then when we launched it, I would be really curious to hear, how did this translate into the real world and into practice?
Yeah, so we kind of worked the model out, and then we spent time meeting with the hospitalists to kind of let them know what it was we anticipated it would look like. We met with nursing leadership in the hospitals, and then we went live. And the way it typically works now is the palliative care consult comes in, Amber reviews it to figure out can she and the chaplain there handle it on their own. And what's interesting is over the year and a quarter that we've been doing this, a larger proportion of the cases, percentage-wise, they are able to manage independently. So they're bringing specialty level nursing and spiritual palliative care, and not necessarily tapping into specialty level social work or provider palliative care. But then when the referral comes through and they do decide a tele-palliative care consult is in order, Amber works with Adie to get the schedule together. After we finish recording this today, at 1:30 this afternoon, we're going to do a consult, and then tomorrow morning at 9, we're going to do a consult. So we just kind of work with the families and the people in Stevens County to see what works schedule-wise. What's been cool is a certain percentage of the time, the hospitalists on site at Mount Carmel or St. Joseph will even be in the room with the patient. Maybe they'll only be in there 10 to 15 minutes, but because they're on site providing the overall medical management, they can answer some of the medical questions and offer some of the procedural information that I might not be as savvy to. I look in the chart, but I'm not the doctor there managing them. So I love it when we can get the local hospitalist to participate. And then Adie and I come in. Adie sort of goes around and asks everybody to introduce themselves. We've had family members from Alaska, Texas, Nova Scotia, and one of the cool things is that now many family members who wouldn't have been able to participate in a family meeting if it was all in person, they're beaming in and participating. And when we talk about beaming in, maybe later on I'll ask Amber to talk a little bit about some of the equipment issues for on-site that we use. And so once we get rolling, it's not all that different than an in-person consult. The thing that is kind of different is when I do in-person consults, it's usually a duet, not the full IDT at the same time. We usually don't, we're more typically asynchronously the full IDT on the in-person consults, but here we have 4 members of the team most often. And by having 2 of us on an iPad or a computer screen, a laptop screen, it's a little less overwhelming to the patient. If all 4 of us came into the room simultaneously, it would be so intimidating. But having Amber, who they know in the room, having Gretchen or Nicholas, the chaplains, who they know in the room, or Sister Linda, that way they actually feel like I have the comfort of having these people and I'm bringing in these outside specialists as part of the team, as opposed as I'm sending you off to the outside specialist. And so it feels much more personalized. And one of my greatest appreciations in this is the intimacy in some of the conversations, and the deeply personal interactions have been much greater than I would have predicted a virtual model would have allowed.
So I have a lot of skepticism in hearing this virtual model, and talk me through how you as an individual provider in alignment with your social worker is able to meet the needs of the patient who's got pain and symptoms. And so much of the palliative care approach is about the communication and about alignment of care. And I love this picture that you just put up for us, because I can see you, and talk to me about what the patient sees versus what the family sees.
So whoever's in the room will see an image very much like this on either one of the hospitals. We still use an iPad on a gooseneck stand. The other, we use a workstation on wheels with a laptop, and so they'll see something like this. And then the workstation on wheels, they actually have a camera that pans a little wider, and so you can see like family members at the bedside. And so we've had as many as 5 family members in the room with Amber. Sometimes the chaplain will actually be on Zoom, or sometimes the chaplain's in the room and Amber is on Zoom. There are different ways. Now the list on the left there, part of our way of doing this is we have an IDT meeting on Mondays and Fridays, and that's all of the palliative care team members, but it includes case management, nursing leaders, hospitalist leader, activities director, a wide variety of people, and we review patients and decide, who seems like an appropriate palliative care patient. And so this is really done in a very highly collaborative manner. The ongoing messaging about current or potential cases, we are DMing back and forth, as Amber mentioned earlier, multiple times per day. The patient in room whatever might need a palliative care consult, and it looks like it's going to be pain management. So Gregg, we really want to make sure you're ready for that. Might be goals of care, really looking into what the needs are. Post-consult debriefs. Many times we will get on a video call and talk things over. Sometimes the post-consult is just a follow-up through the chat function. And it might be, Amber, would you talk to the hospitalist about the thoughts of adding mirtazapine and changing the opioid dose as follows? And the hospitalists work really well with that. There are times I'll communicate with them directly, but they know Amber, and now they know us well enough that usually they find that sort of communication is most effective. The biannual SWOT analysis is where twice per year we look into what are the strengths of the program, what are the weaknesses of the program. That actually led to some of the equipment changes where some of the folks identified that the iPad doesn't work so well for people who are hard of hearing, who have cognitive impairments, are wearing a BiPAP mask or high flow nasal cannula. And then the opportunities, what else could we do? Some of our opportunities are maybe we should look at other facilities to offer this same resource. And then what's the T in SWOT again? I'm blocking.
Threats.
Threats, thank you. I'm nervous being on camera. And so what are the threats to the program? Probably the biggest threat right now is how do you make it financially sustainable? And we're in a large health system, so we can demonstrate the financial benefits. But if you're in a smaller health system, if you're a standalone critical access hospital, making sure that you think about how do we do value-based contracting or setting up arrangements that this will be a financially sustainable model. And then making time to celebrate the success of the team. I've been able to present this material in a few different settings. Kelly and others locally have done a great job of really reaffirming things for the team and letting people know, this team has done just phenomenal work and making sure that they're aware that that's recognized and congratulating them for it.
Wow, that's pretty exciting.
So before you go on, Kevin, I'm just curious, what you see for the future of this whole program?
Well, the sky's the limit really for telemodalities within healthcare as far as I'm concerned. And we have the advantage, like you mentioned, we're part of a large health system. So we do have a fairly robust telehealth partner within the system who has been along the ride with us. But we knew that our own critical access hospitals needed palliative care. The fact that we didn't have them has always been a miss in our conversations, and we've talked about that extensively. But we, with 13 critical access hospitals, is only 1% of the critical access hospitals in the hospital. So the potential for expansion into the communities is huge. But as you know, the far other end of the spectrum we'll get to in just a second is that there are way more people outside of the hospital in need of palliative care than inside of the hospital. So why do you have to be sick enough to get admitted to the hospital in order to get this level of care? But we knew that there was a lot of opportunity, and you mentioned this financial model, and then how do we design it? And everywhere in the world, you're going to be asked, what's your return on investment? What's the bottom line? And can we afford this? And we do palliative care because it's the right care. It improves quality of life. It improves patient satisfaction and caregiver satisfaction. We know this. But then, by the way, it does actually save a lot of money when you align the patient's priorities, preferences, and values with the actual care that's being delivered. I'm going to give a shameless plug to my friend and colleague, Ira Bayak, who has said to me years and years of mentorship, the most expensive care that we could possibly ever give anybody is the care that they don't want. So when we are making sure that we're giving the care that's wanted and needed, when and where the patients are in the critical access hospitals, then we're actually going to hopefully reduce the number of folks coming into the hospital. But
I'm just going to call out, Kevin, I really appreciate you talking about goal-aligned care. Really, this all begins with what is the right care for this individual and how do we match the care that we offer and provide to what they are looking for out of this engagement.
So perfectly put. So we in Providence have some very robust programs, and we have some very skeletal, very bare bones programs. And so we knew that bridging the gap to these critical access hospitals was important, but also we have a program that is a one nurse practitioner program that when she goes on vacation, they have no palliative care. And so how do we support them being able to still have specialty, still have this resource and maintain their well-being through time off, time away, vacation, and God forbid a sprained ankle takes away your entire palliative care team. And so that next step being to support our teams, but also to grow teams and to help them augment as they try to hire and ramp up. But moving upstream, more importantly, the bigger picture is the long-term approach to ensure that folks in the emergency departments have specialty palliative care available, folks in skilled nursing facilities and other residential care settings. But then finally, making sure that folks can get this where they are in their homes, in their primary care in their primary care clinics, in their oncology or cardiovascular clinic settings, where basically, we've joked about this for years. Many of our oncologists and cardiologists want to be able to reach in their lab coat and pull a palliative care doc out and set it on the table. And now with an iPad, we can do that.
Give them the palliative care app. Well, thanks, Kevin. And what I'd like to do now is to transition and have our palliative care team social worker, Dr. Adie Goldberg, who goes as Adie, to run some questions and answers past Kevin and me. So Adie, welcome.
been hard to be quiet with you guys. I've wanted to jump in, but I just want to point out that we did get a question from Polson, Montana, that really asked about that final step in the last slide that you were talking about and what the plans might look like for getting us to really having these conversations earlier and not in the crisis.
Let me jump in, and then I'm going to ask you to augment what I want to say. But we are a very large health system. I know I've said that a couple of times, and I know exactly how many palliative care providers, nurses, social workers, et cetera, we have, and we don't have enough. And our smaller hospitals and smaller settings really struggle in recruitment. But part of that is that there are not enough palliative care providers in the country. And so one of the challenges to that final step, Adie and Polson, hello Polson, I'm glad you were able to join us, is that ensuring the resource allocation is in alignment. Polson, a small critical access hospital in Northwest Montana, is likely never going to be able to stand up a full interdisciplinary palliative care team with a provider, a social worker, a nurse, a chaplain, and even a pharmacist, in some of our larger programs. So how do we ensure that they have that there? And that's through this telehealth model. But out into the community is going to have to take a similar out of the box sort of approach, because you can't pay a palliative care team to sit around and wait until they need you. And I think that you have this really nice quote that I'm just going to call on, that one of your clinical officers came to you and talked about, and I'm just going to ask you to share.
It was the chief administrative officer for Stevens County, and he said, "We don't know when we need you until we need you, or we don't know when we're going to need you until we need you." And so having a telehealth service available is really valuable to them, because that way when they do need us, they can mobilize this process. And the question from Polson about going upstream is kind of interesting too, because how much do you work with primary care with certain subspecialties to try and get those things upstream also? If you're in a larger system, it's a little easier because then it's integrated in the health record. If you're in more of a fragmented sort of system or more independent, will the advanced work you've done, whether it be an advanced directive, a pulsed form, or something else, follow the patient to where they need it? In the inpatient setting, one thing I have been pleased by is we do get most of our consults from the Stevens County hospitals before a crisis happens. The team there recognizes that palliative care is going to have a lot more to offer before a crisis than in the middle of a crisis.
Thanks, Greg and Kevin.
Yeah.
Kevin, did you want to add something before I move you to another question?
Please keep us on task.
Okay, so next question that someone's asking us is how do you do pain management, Greg, when it's remote? Like opioid toxicity. Just curious how you approach these. And Amber, this might be a good one for you to pop in as well.
Well, I have full access to the electronic record, so I can really look at what's being done and what has been done. I also have to recognize I'm a consultant, not the attending, so I don't actually enter orders. And the way our system operates right now, I provide recommendations. And so I do review for the patient who's having significant pain. Probably the ones I've recommended the most are opioid management, antidepressant adjustment, and then the Stevens County pharmacist actually participates as well. So he isn't palliative care certified, but a very sharp palliative care oriented pharmacist. So we collaborate, and then Amber will often then pass the recommendations along to the hospitalist, and the overwhelming majority of the time the hospitalist will adopt those recommendations and move forward. And they're grateful for it. They don't feel like I'm infringing on their turf. They feel like I'm providing a valuable service that they had requested. Amber, do you have anything you'd want to add on that?
No, I agree. I would just say it's a very team-oriented approach to pain management. It's maybe my physical assessment, doctor's knowledge, and then the pharmacist's ability to communicate with the hospitalist with me to get the orders entered. And so it's very effective and it's complex, and I think it's usually 3 or 4 minds into the process. So it does seem to be effective.
Thanks, Amber.
This next question, I think, is really important, and one that we've addressed as a team, where the questioner is asking, how do we sort of balance between doing our work as the specialists in palliative care versus developing boots on the ground resources, that primary palliative care that the local providers and other medical workers can offer in a community. And I know, Amber, we've talked about this a lot. So do you want to start it? And then Greg, you can pick it up.
Yeah, a lot of it has been a culture change. It has been trying to get palliative care as a mainstream idea and thought process here. Having specialty palliative providers like Dr. Gregg and Adie, being able to know that they're kind of in our pocket, it has empowered those of us that are local to really extend ourselves as specialists ourselves and start teaching some of the palliative care things that can be done primary by the rest of the local crew. And, we do work on education. That's probably our next biggest step, is educating on what we can do locally and what the tele team can do. So we're all working at the top of our licensure. I'm really excited to see where that goes forward.
Adie, I think you recall the quote better than I, but when you and I visited Mount Carmel and St. Joseph this spring, some of the charge nurses there, lead nurses, were talking about the culture change that has happened and how they feel that they have learned just by observing what Amber does, what we as a specialty palliative care service offer, that both their orientation to think about palliative care and their skills and confidence in delivering palliative care. And as our friend Linda DeSitter often talks about, if you can raise primary palliative care to a higher level and really have specialty palliative care reserved for those most difficult or complicated cases, it's better patient care, better service, because that way you have all the patients being served with a higher skill set and knowledge base of palliative care, not just the ones who get the specialty consults. So that's part of the other reason why I really value having hospitalists or others participate in the consults, because then they're observing and learning. And just a personal comment, I have been impressed with our younger physicians at how much better their training is in pain management, communication skills than people of my generation. So it gives me some hope for the future to see the overall primary palliative care skill set being so much better integrated within younger trainees.
Amber, I'm wondering if you could speak to the data that shows primary versus telehealth consults that we have done in the first 3 months versus where we're currently at in terms of percentages. Do you have that at the tip of your tongue?
I do. When we looked at our first few months of data, bringing the telehealth team into Stevens County, we were 60% telehealth cases and 40% local or on-site cases. When I just pulled data a few weeks ago, we're 221 cases into the process, and we have flipped. We're now using telehealth 40% of our consults, and locally we're handling 60% of the consults.
So that really does speak to a culture shift and a training shift and a confidence shift. So thanks for that data. Greg and Kevin, you're city guys, and I'm wondering what you've learned about the differences in offering palliative care in the urban population versus the rural communities that we serve in Stevens County.
The first difference I see is just access to resources. The Stevens County, Ferry County, Pend Oreille County cover such a huge geographical area that whether it's home health, hospice, placement in an adult family home, you're covering a lot of territory. And so the resources are just much more scarce. Amber has a quote that I really like, and I may not get it right, so correct me if you need to, Amber, but just because you've chosen to live in a rural area, or just because your destiny, so to speak, was to live in a rural area, doesn't mean you shouldn't have the access to the highest quality of care that anybody else would get in an urban or suburban area. And so to me, there's a real geographical equity issue here, that bringing these specialty services into the community is providing them access to essential services that they might not be able to get on site locally. And so that's been an important element. And then, of course, simple things. You know, I see a lot of rural patients in Olympia, Washington, where I practice because we have a large rural area too. But I don't run into things like the dairy cow schedules complicating things nearly as often as in the suburban or urban practice, or simple things like, can I get enough gas in the truck to go in, especially with the prices as they are today? Who's going to mind the herd, or who's going to take over my job while I go in to take care of mom or dad? So there are a number of things. I don't know, Kevin, if you have anything you would add to that.
I think the biggest variance that I noticed is that urban and these tertiary medical centers are very healing centric, meaning, of course, your desire is to get better. We're going to fix you and send you back home. And the idea that we know best is just completely wrong. Mm-hmm. And so alignment and purposeful engagement of these patients and families in their community, where they are, and making decisions in real time long before they get just automatically transferred to another care center to have the same tests redone and services offered that aren't in alignment with what the patient wants. And so pausing, even if it's just for a couple seconds, to get the patient's perspective, because, you know, if it's a stroke, I don't want you to pause more than a couple of seconds, but there are some of these patients where my going to the big city isn't going to help me, and it's actually going to hurt me because my loved ones are still back in Stevens County, and I'm alone here in this big hospital.
And one other thing I might add is that I've come to appreciate how in rural settings, people feel a more direct connection to the land. You know, they've often been ranchers, farmers, orchards, and they feel really deeply connected to it. So getting back home is something that's really meaningful for people. And so as we do discharge planning, we often will have the discharge planners or case managers involved in the family meeting because they know the local resources in ways that Adie and I, we can talk about them as a general principle, but they can say, well, this home health agency, this hospice agency, this VA related agency can provide the following services to try and get you back to your home on the land. But then again, what are going to be the additional caregiving services to make sure it's a safe home discharge?
So Amber, I know that we are guests and we just had the urban folk say what we've learned, but I'm wondering if there's a point that you want us to know from your perspective of having been born and raised in Stevens County that we missed.
I don't know that we've missed it, but you're right. I was born in this county. I was actually born in this hospital. And what I would want people to know is just that these small hospitals are missing palliative care. The program basically didn't exist before telehealth started. It was rarely utilized. It was not a first thought for really any patient care that happened. And so I just would want people to know that it's possible. It's okay that we're a 1 nurse and 4 chaplain team on the ground because we have all this telehealth support behind us to support the people that are in our community, and they get to stay in our community if they want to. And that's just so valuable.
Thank you. So I'm
Can I throw in one quick question for Gregg?
Oh, please.
Based on what Amber just said, where palliative care wasn't considered before, and now it sounds like it is expected, which I just absolutely love. But Gregg, when you started doing this, and I don't know if Amber, you have this or if Gregg has this, but across the country, somewhere between historically 3% to now 5%, pushing 6% of the patients who come into hospitals see specialty palliative care. What are you guys seeing in Stevens County? What's your impact in the community?
Well, when we talk about penetration, which we define as the percentage of non-OB adult admissions seen by a palliative care referral, I believe, and Amber, correct me if I'm wrong on this, it's around 15% in Stevens County, which is well above national averages.
Sorry, Adie, go ahead.
That's all right. I just am we have just a few minutes left, and I want to make sure that I loop 2 important questions together. And one of them is, if you are thinking about starting a program, what is the one hint that you want to offer today to the listeners about how to begin even considering doing a telehealth hybrid?
Yeah, well, one of the things I learned early on is that coming in with the idea that we have this product that we want to bring to you is far less effective than coming in with humility and saying, what are your community needs? So identifying a champion in the community who knows the community well, and then working together through the champion to identify stakeholders who can really identify what the needs are. And Amber outlined that very nicely at the beginning when she talked about the Stevens County process, how they utilized the resources offered by the Rural Palliative Care Initiative. That's where I also referenced Stratus Health, which we relied heavily on because their research on rural palliative care really outlines nicely what are the priorities and resources. But I think relationships matter first, because if you don't establish the relationships, you're not going to be able to have a program that's really going to succeed.
Amber, is there any advice you would add to what Gregg has just said?
No, just to have that champion. If you have somebody that's passionate about palliative care, it's a good way to get people starting to listen and things brought to your community.
Thanks. So now as we close, I really want to go around to each of you and ask you the question that I ask, which is the surprise, which is, what have you been most surprised by your involvement with this project?
Well, maybe I'll start and say that the thing that really struck me is that once we get into the consult, the interaction with the patient is surprisingly close to what it would be if I was in the room with them. There are occasional times where the technology feels like it's depersonalizing, but actually, I feel like if the technology is used correctly, it's more personalized, because now they've got their family members from other parts of the state or another state on the screen participating. We're able to have this fairly intimate conversation, and once it gets rolling, and I think a lot of people recognize this from FaceTiming with their grandchildren and things like that, you can have as highly personal an encounter via the virtual model as you can have in person. And I think I first learned that from telepsych. I was really skeptical that something that seemed like it needed to be done in person would work well through virtual means, and I was wrong. We really find that the virtual means work very effectively.
Kevin, how about for you? What's your learning?
I have learned so many things about this program. I went into this with a lot of just expectations that have been both supported and completely debunked. I'm a firm believer in the platform and in the process, but just the access. And so the thing that I think that I would say is the coup de grace, the fine point that you need to focus on is that your resources on the ground are as important as the beaming in specialist. You don't have to have the same level of training, education, credentials, silly letters after your name, but that relationship that Amber has with her community really bridges pretty much any gap and can smooth over any concerns that we've experienced. And so the partnership and the collaboration are really what make a program like this work. And I would love to say that without an Amber, you can't do this. And I love Amber, and I think she's phenomenal, but I think that that's replicable. I think that an Amber or someone like Amber with a close tie and a commitment to the community is really the surprise that makes or breaks this sort of a endeavor.
If I can piggyback on that, Kevin, I will point out that Amber did not start this process already a palliative care certified nurse. She comes in with a dialysis and critical care background, and Kelly, who hired her, comments often, hire for fit. Find that person that has the right aptitude, and if it's the right person to do the job, they can learn the knowledge and skills of palliative care. And so over the last year, Amber has become palliative care certified. And so identify people who not only are executive or administrative champions, because if you don't have them, the program won't have the support it needs, but your clinical champions, the people who quote unquote get it, and then they can really train up and provide excellent local service. And I agree with you, Kevin, if you don't have the local expertise, if you don't have that quality of service, the program's just not going to work as well. We're just strangers beaming in then instead of becoming part of the team of this person they know and trust. It makes a huge difference.
So Amber, it's only appropriate that I would give you the last word in all of this. And so what's been your surprise, your learning that you want to make sure everyone who's listening today understands?
My surprise is just that it's possible, that I'm sitting in a 25-bed critical care access hospital who now offers superior palliative care in Stevens County. And growing up here and watching what's traditionally offered here, this is amazing. So it is possible where you are. Even if you're small, you still deserve good care.
So I want to thank all the questioners, and I especially want to thank you all for impromptu answers to my questions. Dr. Gregg, I'm going to turn it over to you.
All right. And quick time check, Amy. 1 minute. Okay. Well, I want to thank everybody for joining us today. And Kevin, Amber, Adie, just been a pleasure to spend this time with you. And this has been recorded, and there will be information in the chat box and how to access that. The next Humanizing Healthcare Expert Series will be in August. Keep an eye out for information about that. It should be in your email box. And we hope that you have a great day and a better tomorrow. Thank you for joining us today.